Good morning, I'm Jessica Lovell and welcome to the Morning Medical Update. All this month we have been celebrating breast cancer survivors, patients, and the people who support them. Millions of those survivors end up facing a condition that is life-changing in and of its own. Lymphedema is a condition typically linked to swelling of the arms or legs. It is not unique to breast cancer patients, but the two often go hand in hand simply because there are lymph nodes in and around the breast. Today, we're going to learn how lymphedema can impact someone's everyday life. We'll see what doctors can do to detect it and treat it. And we'll also meet a breast cancer survivor who might not have to deal with lymphedema at all thanks to a special procedure. Today, we are joined by two surgeons. Both of them are the co-directors of the lymphedema program here at the University of Kansas Cancer Center. They are Dr. Lyndsey Kilgore. She is a breast surgical oncologist performing surgeries like mastectomies and lumpectomies. We also have across from me Dr. James Butterworth. He is a plastic surgeon who does a lot of breast reconstruction for cancer patients. But today, he will help us understand that special procedure that we're talking about that actually more patients need to know about in deciding on their surgery options. And we're also thrilled to have one of their patients with us, Adrienne Adams. She was diagnosed with breast cancer in May of 2022. So glad to have you here with us today.
Thank you. I'm glad to be here.
Yeah, so let's start with you. You had actually learned that you had cancer, and this was around the same time that you were actually supposed to head out of town on a conference, just working like the rest of us have to do, but you decided not to cancel the trip. Why is that?
Well, I figured that, I got the diagnosis, I was here at work, and it was headed into the weekend. And so I didn't know a whole lot. You know, with the exception of just that I had breast cancer. And the conference was going to be fun. And it was with my sorority, and I was traveling down to Des Moines with my sorority sisters. And I felt that I needed something to take my mind off of something that I didn't know a whole lot about. And I didn't want to sit at home crying.
Well, I was just thinking, I like that attitude because you mentioned sorority sisters. I can't think of better people to be around when you've been diagnosed with something like that, and just having that support and love surrounding you. You went through 4 months of chemo. You had that support. You shared also some photos of some work friends. And full disclosure, Adrienne works right here at the health system. What was it like just knowing that support was literally everywhere around you?
Oh my gosh. Totally awesome. My manager, Scott Wansley, one of the things he initially told me is not to worry. Don't worry about your job. And then my team was so supportive throughout. They gave me a party, basket of goods, and just super supportive and there for me throughout my treatment. When I wasn't feeling bad, they could sense it. I mean, wasn't feeling good. They could sense it, and you know, they were kind and
kind of a "we've got you" approach.
Absolutely,
they've got your back.
They've got your back. Awesome,
of course, family and friends outside of the health system support for you as well. Talk about them.
Yes, my best friend, my daughters. My significant other and his daughter, who is also my daughter, I may as well say, and the 3 lovely children, and then my sister friends. They were all right there, front and center from the very beginning, and it was just breathtaking and refreshing.
Breathtaking, yeah. And you finished chemo, and then you got to ring the bell in October of 2022,
I did.
Almost exactly a year ago. Talk to us a little bit about what that was like, having everybody there surrounding you that day.
Well, joy, relief. Again, I had family and friends and sorority there to cheer me on and to be with me during appointments and sitting with me during treatment, and then there at the end to ring the bell. It was just knowing that I had gotten over that hump was just really felt good.
And I'm sure you'd heard stories about people ringing that bell, and it felt probably in the beginning so daunting and so far out in the future, and then here it is, the day is here.
Right.
You're going to put it behind you.
Exactly.
Kind of, in a way, because you ended up needing surgery, right?
I did.
That's going to bring us to the focus of our program today. Along with your double mastectomy, you were offered a procedure called immediate lymphatic reconstruction, ILR. What do you remember, Adrienne, about what doctors told you about what this was going to entail?
Okay, so I was given lots of information, and when I first met with Dr. Kilgore, she explained the procedure to me, and she talked about the procedure that could help prevent lymphedema, and so she talked about it quite a bit. And then that was the first visit, and then the second visit, which was I believe in August of that year, she talked about it some more. And I was on board immediately because I had cancer, and I knew that with the removal of lymph nodes, or I understood that with the removal of lymph nodes, that there was a risk of lymphedema. And I didn't want anything else to add to the picture. I wanted to be as healthy as I could be without other things that could complicate what I had to go through.
Yeah, you were done, ready to get back to life.
I was done.
Fair enough. Dr. Kilgore, so establish a little bit about what the lymphatic system is. How does it relate to breast cancer, the treatment? Who gets it?
Right. You know, what I commonly explain to patients when they're in my office is that the lymphatic system is like filtering toxins throughout your body. You have these lymph channels from the tips of your fingers to the tips of your toes. And when we deal with breast cancer, we're dealing with the lymph nodes under the armpit. That's how we stage breast cancers, treat breast cancers, and helps us understand treatments for them. And so when you're doing your breast cancer operation, we commonly remove lymph nodes. And depending upon how advanced the breast cancer is, sometimes we have to remove all the lymph nodes under the armpit, which is the case for Adrienne. And so when we do that, we know that there's a higher risk of those lymph channels having traffic buildup. So I talk about it like traffic building up on a highway. The more bridges that are taken out, traffic can build up in the arm. So we've got to figure out a way to reroute traffic or cause detours. And that's where the immediate lymphatic reconstruction comes in.
So how common is lymphedema, and who gets it? Everybody is susceptible if they've had breast cancer?
So not just breast cancer, we know that if you've had nodal surgery for your breast cancer, that's what puts you at the most increased risk, especially patients that have to have all their lymph nodes removed and not just the sampling. And so we warn all of our breast cancer patients about that risk, and that it can be reported in the literature upwards of 40 to 60% of all breast cancer patients that undergo the bigger lymph node procedure. And that's why here at KU we have some of the lowest rates in the entire country, not only because of our early detection and prevention program, but because of procedures like the immediate lymphatic reconstruction procedure that Adrienne had.
So most of us think of those obvious lymphedema symptoms like swelling of the arms and the legs. We could see it here in this photo. Other symptoms?
Yeah, you know, the common complaints that we get are heaviness, achiness of the arm, tightness when they're wearing watches, jewelry, and then also they're at more risk for infections of that arm too if they have lymphedema, and then they can get infections that can cause severe pain as well.
So Dr. Butterworth, let's bring you in here. You perform these ILR, immediate lymphatic reconstruction procedures. We're the only hospital in the region that offers this. Well, tell us more about that and why it's not more common.
Yeah, we're doing it certainly on scale. It's a growing procedure that you're seeing around, and I think there are some places that are closer that are starting to do it, but we've been doing it for a while now, and our lymphedema program is certainly something that we established over 10 years ago and continues to be, moving at a great pace, and having this as part of our process is something that I think has been very important to offer patients.
So kind of take us inside this procedure. How does it work? What are you actually doing when you get in there with a patient?
Yeah, so it's extremely collaborative between the breast surgeon and the plastic surgeon that are doing it. And so when we go about doing it, and when I'm working with Dr. Kilgore or one of her partners, it's something in which we discuss beforehand. Before they start their part of the operation, we have to inject dye into the arm in order to identify where the lymphatic channels are that Dr. Kilgore was talking about. And then during her part of the operation, she has to identify those channels clip them, and then find veins for us to put them back together. And then my part, in a very simplistic way, is just putting tubes to tubes or reconnecting plumbing. And it's not as simple because it's at such a small level, and we're using suture that is difficult to see with the naked eye, but we use high-powered loops or microscopes to come in and then reconnect the lymphatic channels into the venous system so there isn't that obstruction or roadblock like what Dr. Kilgore was talking about.
You make it sound so easy. Just some replumbing, no big deal. So a patient like Adrienne has a mastectomy. Are you doing this on the same day?
We are. Yeah, we are. We try to do as much as we can during that time in order to keep the needle moving and the cancer care being done.
So yeah, quite an orchestrated operation, literally. How effective is it? Could Adrienne end up dealing with some type of lymphedema down the road?
So like with all things in medicine, nothing's 100%. But as Dr. Kilgore had mentioned, you know, the chances of developing lymphedema, especially with people that are high risk, so an axillary lymph node dissection, removal of all of the lymph nodes, radiation afterwards, certain types of chemotherapy, can have a risk of about 40 to 60%. We think that based on the literature that's been published as well as ongoing studies, that doing these immediate lymphatic reconstructions will drop that down to well below 10%.
So you've kind of touched on it, but why was Adrienne such a good candidate for ILR? You know, if this is preventative, why not every breast cancer patient?
Well, that's really the goal. And so one of the things that we knew about Adrienne going into the operation is that she needed to have all of her lymph nodes removed. And in that, we were able to plan for it and then able to execute it. And so we're hopeful to be able to roll that out to all patients. But right now, all patients that we are identifying that are requiring their lymph nodes to be removed are getting it here.
All right. Yes.
I think you mentioned, you know, it's really a coordination of care, and that's something that we at KU take pride in. You know, it takes a lot more time and effort to coordinate these surgeries, but we believe that it's in the patient's best interest, and so we take that time to do so.
So Adrienne, you were ready to take all of this on, do whatever you got to do to get me up and running. What was recovery like?
I was. Interesting.
Let us have it.
I came out with 4 drains, and so it wasn't as easy as I thought it would be. 4 drains, lots of discomfort, the inability to shower by myself or without help. Let me put it that way. I could shower, but you know, I needed help. Just with some of the basic things, but I didn't have any complications, which was pretty awesome, I thought. And so it's just going through the everyday trials of getting better and not having the pity parties and being surrounded by family and friends who were there the moment I needed anything. And so, you know, that makes going through something like this a lot easier to handle. So
as easy as it can be makes the big difference.
Absolutely.
So a question many might be wondering is if somebody already has lymphedema, does a procedure like this work? Or is it only beforehand?
Yeah, so our goal is really on prevention. That's what this procedure is to prevent lymphedema from even happening. But then if we do detect lymphedema, detecting it in its earlier stages where it's actually reversible. Because when you develop chronic lymphedema, it's not reversible, and then you just need Dr. Butterworth's team to help treat some of your symptoms.
All right, so that was it. If it was reversible, that was my next question. Tell us about the machine that you have in clinic that actually helps you detect lymphedema.
Yeah, so the machine that we have is the SOZO machine. This is a bioimpedance spectroscopy. Fancy words for basically detecting your baseline lymphatic flow. And so patients, all they have to do is step up on the machine like you see in the video, and it detects their flow of their lymphatics. And then what we do is we monitor that flow moving forward. So we detect their subtle changes, and if we detect changes from their baseline, then we can intervene.
So is this anyone who has breast cancer, or is this anyone who's at risk of lymphedema?
This is anyone who has breast cancer surgery at the University of Kansas Health System.
And then you measure their arms. What are you looking for in changes in those measurements?
Yeah, so that's for our higher risk patients that undergo that full lymph node surgery. We not only want to have the SOZO machine, but we want to have arm measurements too, because we want to make sure that we're truly detecting it early so that we can intervene if we need to. And this way we have 2 ways to look for it.
So Dr. Butterworth, Dr. Kilgore mentioned other surgery options for someone who has chronic or severe lymphedema. What are those other options?
So we can do things for patients that have chronic lymphedema. We think about them in a couple of sort of larger categories, debulking and then physiologic operations. As Dr. Kilgore mentioned, by far the best way to deal with lymphedema is to try to prevent it, though.
Absolutely.
Those operations can help manage it, and they can help out with compressive therapy and the conservative management that we continue to do with patients with established lymphedema through either liposuction or doing this type of operation that we do with the immediate lymphatic reconstruction, but further down the arm. Once you've developed that level of chronicity of that lymphedema, though, that's not a cure. And so at that point, it really does just help manage the signs and symptoms of lymphedema, make patients a little bit more comfortable, but it becomes a lifelong process, going back to the importance of prevention.
So I mentioned off the top, you're both co-directors of the lymphedema program here at the Cancer Center. Just reiterate again, just what that difference makes. A program like ours, what kind of difference that makes for a patient like Adrienne? Well, again,
back to what Dr. Kilgore was saying, I think one of the things that we've really strived to do is to have a collaboration of care and amongst multiple different disciplines in order to really provide the optimal care. And lymphedema is a very complex disease process that requires physical therapists, occupational therapists that are in the form of certified lymphedema therapists, as well as people like surgeons like Dr. Kilgore and myself. People in vascular medicine, we've got a great partner there, and our vascular surgeons. But in order to really optimize the way to navigate a patient is through that level of collaboration and a multidisciplinary approach.
And I love like one and done. 2 operations right at once, one caring for the illness you have of breast cancer, but then prevention right all in the same day. So that's quite a big deal. If you have questions, be sure to get those in on the chat on YouTube or Facebook. You can tweet us or email the Medical News Network. Info is right there on your screen. Let's get a check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Yeah. You've got such a big title.
It's only been 3 years. Don't worry.
I'll get it. I swear. Give me another 3.
Yeah, so right now we have 20 active patients in the hospital, again up a little bit from last week, but it is down from 2 weeks ago when we had 22 active patients. Overall, we'll just have to wait to see the trend. Hopefully it will stay under that 20 mark. And right now, again, really no influenza hospitalizations currently as well.
All right, Hawk, a new study published this week gives us another clue into long COVID. Researchers from University of Pennsylvania linked long COVID to reduced serotonin levels. Low serotonin can disrupt the nervous system, and I guess might explain brain fog, as we used to talk about when it came to long COVID symptoms. But what are your thoughts on that?
Yeah, you know, maybe a little bit. I think we are getting to answering these questions, certainly asking them, but answering them on the most basic levels of the mechanisms of what is going on. And then we find these data signals that may lead us to therapy. Now, just with this doesn't mean that everybody should get on serotonin medicine. We know that there can be side effects with those as well. But this is one more step to just really understanding the underlying mechanisms of what's going on, because we know this sort of thing, long COVID, but other things such as chronic fatigue, which have been really similar to this, and people have made those analogies, but we know these affect people's daily lives on a regular basis, and will continue to do that as well. So we are learning the basic mechanisms of what causes people's symptoms. But again, long COVID is a variation of different things. It is the lung symptoms, cough and shortness of breath, the brain fog, just as you mentioned, the fatigue. So we are learning mechanisms and really the reasons why these things may be persisting in people who have had COVID-19 and still have these lingering symptoms as well. Now, what do we do for treatment? That will be the next step in really understanding how do we best manage these things moving forward.
All right, Hawk, thanks so much.
Yeah.
Let's get to some questions from our viewers. First question is there any evidence that lymphatic massage does anything to prevent lymphedema?
Yeah, so we actually use manual lymphatic massage when patients have early signs of lymphedema. That's one of the home interventions that we teach our patients. And we don't make them have to see a therapist. We teach them so that they can do it at home, because a lot of patients don't have the convenience to come in for appointments where someone else is doing it for them. So.
Very interesting. Jeremy wants to know, what is the typical expected recovery from ILL procedures itself? You mentioned your recovery. Is that pretty typical, Dr. Butterworth, Dr. Kilgore?
Yeah, it's a big operation,
yeah.
In terms of having the mastectomies and the immediate lymphatic reconstruction. I think from the lymph node removal and in the reconstruction standpoint, that's, I think, fairly straightforward. The one thing that we do ask them to do is to not raise their shoulder above 90 degrees, just because the connection between the lymphatics and the veins is just, it's so small in terms of the sutures that we use. But then beyond that, we let patients do free range of motion and then ultimately get back to their normal lives.
And I think it's interesting to point out too is that you don't have to have a mastectomy to have the axillary lymph node dissection. So some women don't want to undergo the breast reconstruction, but they still want to be able to have the lymphatic reconstruction. And so we're able to still offer that in combination with lumpectomy or total mastectomy, where a woman is left flat. So it's still an option for all patients, regardless of if they want to pursue the breast reconstruction or not.
Very important to know that. Okay, so Yen wants to know, some breast cancer patients require lymph node removal, as we've talked about. Would the circulatory problems after lymph node removal affect the heart or lungs? Is there any, when we talk about the plumbing, is anything interrupting anything else?
No, we haven't seen issues with that. And honestly, with the axillary lymph node dissection, we're only removing a package that's called levels 1 and 2. So we're not removing the entire lymph system under that armpit. So you still have some lymph channels that are helping filter those toxins.
Does insurance cover lymphatic reconstruction? Elsie wants to know.
Yeah, that's a bit of a hot topic, especially amongst those of us that do lymphedema surgery, and trying to push hard at a national level and advocate with regards to our CPT codes and with regulation. And so,
are you saying insurance companies are hard to deal with? Is this what you're telling me?
well, long answer short, sometimes.
Okay.
So, I will say that we are very fortunate to work for a very benevolent institution in which we've had long discussions with them regarding the importance of this operation and what it can do for patients, and they see that, and so they are committed to help offload the financial burden for patients.
And does that happen when a new procedure comes to the table?
It can.
Okay.
Yeah, it can.
That makes sense. All right, I want to get our takeaways today, and Dr. Butterworth, I'll start with you. What do you want the big takeaway to be from our chat today?
Well, I think it's important for patients, physicians, anybody in the medical field to really understand better what lymphedema is and what we can offer in order to help. It can be a very debilitating condition once it develops, and certainly the aim to prevent it is where we need to be, and to continue to push that needle forward. And we're doing what we can and continue to offer as much as we can to our patients here.
Dr. Kilgore.
Yeah, I would echo the same thing and just really say that it takes the whole team approach, like we've mentioned multiple times, and that's what KU has to offer. Being a comprehensive cancer center, being a comprehensive lymphedema center of excellence, we really have all the people, all the resources, and if you get your cancer care here and have your surgery here, we will let you know if you qualify for this. We want to offer it to you, and even if you don't qualify for this procedure, we have an amazing screening program, and we'll surveil you and intervene early if we need to.
So on that note, if somebody far, far from here is listening to this and maybe where they're at and their healthcare providers don't offer this, what kind of questions should they be asking?
I think just asking your surgeon, you know, what are you going to be doing? Are you doing lymph node procedures? Do you have surveillance programs? We're very unique here at KU, so not many people can offer this, and that's one of the benefits of coming to the University of Kansas Cancer Center, is having the people who can do this and can monitor you moving forward.
So pick up the phone and call, is what you're saying. I gotcha.
Yes.
Adrienne, let's end with you. What's the big takeaway from your story?
I had an amazing, and continue to have an amazing team here, and I trust them. And I think they gave me great information to help me make a decision that I think will be beneficial, a lifelong benefit to me. And so, you know, if anyone is presented with, you know, the same opportunities, I say go for it. Go for it.
Thank you so much for sharing your story today, and I'm just glad you're doing well.
Thank you.
Stay in touch with us. We'll do an update on you.
All right.
All right. All right, a special episode of the Morning Medical Update dedicated to breast cancer will air on KCTV5 and WIBW this morning. Here's a preview. Coming up next week.
I just was taking a shower, washing, and then I felt a lump.
Breast cancer, from diagnosis to treatment and beyond.
So many people keep telling me how strong I am, and it's not that I'm trying to be strong, it's just I have 4 kids that need me.
Since the moment I was diagnosed, I wanted to get this thing out of me.
Specialized doctors working together, improving the odds of survival.
Someone you love will live because of this cancer center.
Cancer, Choices, Hope, and Science airs today at 9:30 here in Kansas City on KCTV5, and then also in the Topeka area at 9 a.m. on WIBW. It's a great episode, so check it out if you can here in about 1 hour on KCTV5 here in Kansas City. And thanks to all of our viewers for being with us today. We'll see you back here tomorrow at 8 o'clock. Breast cancer survivors deserve the chest they want, and they shouldn't be ashamed to ask for options. I'm Jessica Lovell on the next Open Mics with Dr. Stites. Whether it's implants, natural tissue, or something else, we explore the choices women have. Wednesday at 8.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.